The purpose of this video is to review steps to successfully treat a left shoulder Bankart tear utilizing an all-arthroscopic technique. The patient has suffered a traumatic anterior shoulder dislocation with multiple subsequent subluxations and has failed conservative treatment. In this procedure, double-loaded suture fix anchors are utilized to complete the labral repair while the patient is in the lateral decubitus position. This is a patient in the lateral decubitus position while an examination under anesthesia is performed. The shoulder is able to be completely dislocated anteriorly with an anterior and inferior directed force while the shoulder is in abduction and external rotation. The glenohumeral joint is viewed through the posterior portal. When establishing the anterior portal, use an arthroscopic needle first to make sure that the tip of the needle is able to touch everywhere in the joint that you need to work. Note the low location of the portal in relation to the rotator interval. An incision is made and a 5.5 millimeter clear track cannula is introduced through the rotator interval. A 4.5 millimeter radius bone cutter shaver is introduced to flush the joint. The camera is in the posterior portal looking anteriorly. Note the entire anterior labrum is torn and displaced medially onto the neck of the glenoid. A liberator is used to assess and mobilize the labrum. A second portal is established anteriorly. An arthroscopic needle is brought into view just anterior to the long head of the biceps in order to localize an ideal position for an anterior superior portal through the most superior portion of the rotator interval. Note the distance between this portal and the previously established anterior-inferior portal. Placing these two portals too closely together may cause crowding of the anterior working space in the rotator interval. A 5.5 millimeter cannula is placed anterior superiorly. The camera is then moved from the posterior portal to this new anterior superior location. The posterior labrum is intact, as is the posterior capsule. The anterior labrum is detached from the glenoid and displaced medially. An elevator is inserted through the anterior-inferior cannula in order to elevate the labrum off the neck of the glenoid. Note the labrum not only is brought laterally, but anteriorly, so that the tissue is pliable and able to be shifted superiorly when reattached with suture anchors. Full mobilization of the labrum is noted here. The camera has now been placed posteriorly and a 5.5 millimeter clear track cannula is placed superiorly while an 8.5 millimeter clear track cannula is placed inferiorly. From this view, the biceps long head is to the right of the screen. The anterior neck of the glenoid is lightly abraded with the suction in the off position in order to protect the torn labrum. Note the labrum is now mobile and prepared for repair. An arthroscopic grasper is utilized to advance the labrum superiorly to assist in the capsular shift of the tissue onto the glenoid. A crown tip suture fix drill guide is inserted through the anterior-inferior cannula onto the face of the glenoid at the 7 o'clock position. Care is taken to hold the guide still throughout the procedure. The blunt obturator is removed and the 1.9 millimeter drill is inserted. Note that the drill depth is 20 millimeters. The double-loaded 1.9 millimeter suture fix anchor is then tapped into place down to a positive stop on the collar of the drill guide. The white button is pushed until a pop is heard. With the palm of my hand, I am holding downward pressure onto the end of the anchor toward the bone while pulling the purple sliding wings toward the end of the anchor. Completion of this maneuver is confirmed with an audible click of the anchor indicating that the suture anchor beneath the bone has been deployed. Sutures are removed from the suture anchor handle. Gentle tension demonstrates that the anchor is firmly secured in the bone. An elite premium suture grasper is introduced through the anterior superior cannula in order to retrieve 3 of the 4 suture limbs. The 2 white sutures and the 1 blue suture are parked into the superior cannula away from the inferior cannula. An AccuPass suture shuttle device is then placed through the inferior cannula and around the anterior-inferior labrum at approximately the 6 o'clock position. The black monofilament loop is advanced into the joint and retrieved through the superior cannula using a hook. The blue-colored suture is then threaded through the black loop. The AccuPass is pulled out in a reverse manner from the inferior cannula, pulling with it the blue suture that is now shuttled through the tissue and around the labrum. A distal locking sliding knot is then tied. A knot pusher is then placed onto the post and the knot is advanced into the joint. One of the 2 white sutures that remain in the superior cannula is shuttled into the inferior cannula using a crochet hook. With the 2 sutures separated, the AccuPass may now be introduced into the inferior cannula. This particular suture is then passed inferior to the first stitch in order to reinforce the anterior-inferior repair. A second knot is then tied and cut. The 1.9 mm drill is inserted, followed by placement of the second 1.9 mm anchor. The anchor is tapped into the bone. The white button is clicked into place. The anchor is deployed, and the sutures are removed from the handle. The 3 suture limbs are then retrieved, again through the anterior superior cannula. The AccuPass is then inserted through the inferior cannula again, and the black suture loop is advanced into the glenohumeral joint. The black suture loop is retrieved through the superior cannula. The blue suture is inserted into the loop. The AccuPass is then reversed out of the inferior cannula and thereby shuttling the suture with it around the labrum. The sutures are then tied to the anterior-inferior cannula and then cut. Note the shift of the tissue superiorly as the knot is tied. The AccuPass is placed a second time around the labrum with the second anchor. The suture is then tied and cut. A third anchor has been placed at the 10:30 position, and the white suture of the anchor has been shuttled around the labrum. The suture is then tied and cut. The slap component of the labral tear is then addressed. The superior glenoid neck is debrided to a stable edge. A crown suture-fixed drill guide is inserted through the anterior superior portal and brought posteriorly to the long head of the biceps interarticularly. The blunt obturator is removed, and the 1.9 mm drill is passed to the positive stop on the guide. A 1.9 mm suture fix anchor is inserted and deployed. The handle is removed and gentle tension is applied to test the stability of the anchor. A single ultrabraid co-braid suture is retrieved through the anterior-inferior portal. An arthropierce is introduced through the anterior-superior portal and brought posterior to the biceps long head. The white suture is retrieved with an arthropierce. Both suture limbs are shuttled to the anterior-inferior cannula and tied posterior to the biceps. Care is taken to ensure the knot is in the gutter behind the labrum and away from the articular cartilage of the glenoid. The arthropierce is placed a second time through the anterior superior portal, and the remaining blue suture is shuttled around the labrum in a retrograde fashion anterior to the biceps tendon. The sutures are tied and cut. Note the suture knots are off the face of the glenoid posterior to the biceps. The remaining superior Bankart repair is then repaired after the slap repair is complete. The drill guide is introduced once again through the anterior-inferior cannula and the obturator is removed. The anchor is deployed and the handle is removed. The suture is passed with the accupass and tied. While continuing to view through the posterior portal, the posterior portion of the slap is probed. Using a Wilmington percutaneous portal, an additional 1.9 mm suture fix is placed and deployed. Through the anterior superior portal, the arthropierce is utilized to grasp and shuttle the suture. The sutures are tied through the anterior superior portal to complete the repair. Final evaluation while looking through the anterior superior portal demonstrates the posterior superior portion of the slap has been corrected. Looking down the anterior face of the glenoid, the anterior inferior labrum has also been reattached inferiorly all the way up to the superior portion of the glenoid. The humeral head is also centered nicely on the glenoid face. The arm is taken out of the balance suspension arm holder for clinical evaluation. The shoulder is stable to load and shift at the conclusion of the procedure. After the procedure, the patient is placed in a sling and physical therapy is started around 10 days out from surgery. Passive range of motion is allowed, but the sling is recommended for 6 weeks. The patient is transitioned to a workout program at 12 to 16 weeks postoperatively.